Good afternoon. I'm Monica Feit, Executive Director of the Health and Medicine Division of the National Academies of Sciences, Engineering, and Medicine. Welcome to the first session in our new quarterly webinar series, A Healthy Exchange. We created this series to connect you directly with experts who can explain and further explore timely health-related topics that are spurring national conversation. One such topic is a type of drug known as GLP-1s. They've gained tremendous visibility recently due to their connection with weight loss. It seems like every week there's a headline about them in the news and a lot of chatter on social media. Scientifically known as glucagon-like peptide-1 receptor agonist, these drugs are primarily used for the treatment of diabetes, obesity, and heart disease. Now, some GLP-1s are used exclusively for weight loss. And researchers are also evaluating their potential for treating other conditions such as eating disorders and addiction. This is an area not only of intense scientific interest, but also of great public interest because GLP-1s are having a growing impact on people's lives. Questions are emerging around access, implications for weight bias, and more. As with many topics that quickly gain cultural attention, there is still some confusion out there about GLP-1s and where we're headed as a society. So that's why we're here today. The National Academies have done a good bit of work in this subject area. Our Forum on Neuroscience and Nervous System Disorders recently held a workshop that brought together leaders and experts from academia, industry, government, and other groups to examine potential applications of GLP-1s in disorders such as dementia, Parkinson's disease, substance and alcohol use disorders, and pain. And our roundtable on obesity solutions held a workshop to explore medications and advancing comprehensive care that focused on lived experience and attention to weight bias and stigma. The workshop also addressed the implications of pharmacotherapy for obesity on policy and legislation, economics, access, public perception and discourse, and population health. Here in the Health and Medicine Division, our convening activities, such as our forums and our roundtables, are real sources of innovation, and I encourage everyone to check out the links that we'll provide in just a little bit. I want to thank each of you for joining our discussion today. We hope this healthy exchange will facilitate a deeper understanding of GLP-1s and the many factors that all of us collectively should consider as we continue to dive deeper. Now it's my pleasure to introduce our moderator and my colleague from the National Academy's Office of News and Public Information, Megan Lowry.
Thanks, Monica. Good afternoon, everyone. My name is Megan Lowry, and I'm excited to be your moderator for today's event. Thanks, Monica, for those opening remarks and for setting the stage for us. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, engineering, and medicine. The National Academies is a nonpartisan institution, and I'll note that discussions here do not constitute the viewpoint of the academies, nor do they constitute advice or recommendations, and we are also unable to offer individual medical advice during today's event. Before I introduce our panelists, I'll also note for the audience that today's webinar will be 1 hour. So we're going to start off with some questions that I have for our experts, and then we're going to open it up to any questions that you have. You can submit a question at any time during our discussion, and you can do so by using the Slido box below your video player. It's on the same page that you're on right now. You can also upvote any questions that you like and want to hear. So without further ado, I'm excited to be joined today by Jamy Ard, Professor, Vice Dean of Clinical Research at Wake Forest University School of Medicine, and a professor in the Department of Epidemiology and Prevention, Ania Jastreboff, Director of the Yale Obesity Research Center YWeight, and Associate Professor in Medicine and Pediatrics Endocrinology at Yale School of Medicine. We also have Panelist, immediate past chair of the National Board of Directors of the Obesity Action Coalition, and the chair of the OAC's Weight Bias Committee. And finally, Donna Ryan, Professor Emerita at Pennington Biomedical in Baton Rouge, Louisiana, where she had a 25-year career in clinical research in obesity. So welcome to all of you, and thank you again so much for being a part of today's conversation. I think between you all, we have several very important expert perspectives represented for today's discussion on how these drugs are changing our health and changing the way the medical system is adapting. So let's dive in and explore this issue. My first question for you all is, the way new injectable medications to treat obesity and diabetes have been talked about in popular media sometimes makes them seem like a magic pill. One medication that can help people lose weight, control their diabetes, and possibly treat other conditions as well. So how do these drugs work, and why are we hearing so much about them? Jamy, maybe you can get us started.
Sure. Thanks, Megan. Glad to be here. So how do these medications work? Well, these medications were originally developed and sold and marketed for the treatment of type 2 diabetes because GLP-1 is a incretin hormone, something that we naturally produce, and it's used to help regulate blood glucose. But we also found out that it actually has an impact on food intake, and these receptors for the GLP-1 molecule are throughout the body, including in the GI tract and in the brain. And those receptors in the brain are really where the food intake control happens. And so over time, we realize, well, if we give people this medication and formulate it in a way that it's actually able to stay around in the body for a sufficient amount of time, you can actually get people to have a significant reduction in food intake, and that leads to weight reduction. And so the medications have evolved over time. So it's not as if GLP-1s are just new, in the past 2 years. We've actually been working with them for many years, actually almost a couple decades now. And it's, now an evolution. And the reason that we're really, sort of focused on this and why this is a topic of interest to even have a webinar like this is because we're seeing much more impact for this category of medications compared to the past. So, for example, some of our earlier generation medications, what we might call our first or second generation medications to treat obesity, even the earliest GLP-1 that was approved for the treatment of obesity, liraglutide, those medications generally will get people, if I take 10 people and treat them in my clinic, 3 to 5 out of 10 will get at least a 10% weight reduction. And we look at the percent weight loss as a way to sort of understand how much health benefit people might get. And so when we start to get above 5%, that's good. 10% or more is definitely better and leads to more health improvement. And so with these older medications, we are getting, 3 to 5 people out of 10 might get some health benefit at that 10% weight reduction target. Well, what we're seeing with the newer medications is that now we're in the range of almost 8 to 9 people out of 10 will hit that target of at least 10% weight reduction. And the average is even higher than that, right? We're in the 15 to 20% range in terms of average weight reduction across a broad number of people. So this is why we're really excited about that, because we also know that if we can get more weight loss safely, then we also see more health benefit for a lot of our patients. And it means that this has now become much easier for us to help our patients when we have more tools in the toolbox.
Great, thank you, Jamy. Anyone else want to jump in on this first question, how they work, why we're hearing so much about them? If not, I have plenty more questions for you.
Yeah, so I'll just jump in and talk a little bit about the biology as well. And I think this may lead into the next part of the discussion as well. But, our body is amazing, and it developed this amazing biology to make sure that we have enough energy to do all the things we need to do. And the way that it figured out how to store energy is to store it as fat. So fat is a good thing. This is good. We want to survive as a species. Now, one might ask, well, if we develop this amazing system that Jamy just described, where hormones communicate with the brain and they let us know how much energy we should store or how much fat we should store, then why is it that so many people have obesity? Why is it that half of Americans have obesity? And the answer is the obesogenic environment. So an environment that is filled with ultra-processed food and lack of sleep and lack of physical activity and a whole lot of stress. And that obesogenic environment on a population level has led so many of us to carry extra weight or extra fat specifically. And so, two things from that. One is we really need to work on that environment, right? The environment that got us here in the first place. And the second thing is that for the people who already have obesity, we have to provide them with treatment or the option for treatment if they are seeking that treatment. And for any other disease, we would offer, whether it's medications or in this case, medications or surgery, as well as diet, physical activity, counseling. So it's all of these things together. But I think, again, as we treat any other disease, targeting the biology, what we need to do is target the biology of obesity. And that's exactly what we think these medications do. They target the neurometabolic biology of obesity.
Thank you. And that leads in perfectly to my next question, which is for you, Ania. Can you give us the big picture here? Since these drugs have become available, how have they changed things for patients being treated for diabetes, heart disease, and obesity, and for the medical professionals such as yourself working with them?
Yeah, I think that these medications really are transformative. They're transformative for patients in terms of their life, their health, and for the providers who for all of us who are treating patients. I think we're so grateful that, as Jamy said, we now have so many more tools in our toolbox and highly effective tools. And I think with obesity, if we think about it, what other disease can we treat and in essence treat hundreds of others, right? So if we think about the diseases you just mentioned, diabetes, heart disease, all of these diseases are obesity-related diseases. So if we treat obesity effectively, then we can potentially treat, mitigate, if not prevent, hundreds of other diseases. And we've mentioned diabetes and heart disease, but it's potentially, multiple types of cancer. It's hypertension, it's knee pain, it's obstructive sleep apnea. There are so many things that we can impact by effectively treating one disease, and that's obesity. And so the take home is when we're treating obesity, it's not just about weight reduction. It's about optimizing health and improving health. So that's what we need to keep in mind.
Thank you. I see some nods. Anyone else want to tackle this question? And then I have one for Donna after that. All right, I think Ania covered all of it. Donna, turning to you, most people have seen the success stories, but on average, what can research tell us about how well or how poorly these drugs are working for most people? And are there any side effects or risks that you want people to know about?
Yeah, I really like the way Jamy set this up with it all goes back to GLP-1, this naturally occurring hormone that's released in our intestine after a meal. It's stimulated when nutrients reach that intestine. It's stimulated, and so the good news about the GLP-1 derived medications is that they have a lot of homology to native GLP-1, so we don't really see off-target effects. They're powerful medications. We need to respect them. They have powerful effects on appetite. These newer medications like semaglutide and tirzepatide do. And so I think we need to recognize that we need to sometimes manage that dramatic reduction in appetite and be careful about the amount of weight loss that people are achieving and the rapidity of the weight loss. Because we know from our experience using very low calorie diets that it is sometimes unsafe to lose weight too rapidly and to lose too much weight. So, but this native hormone, it also has effects throughout the body. And so one of the effects of the GLP-1 medications that we have to watch out for is delayed gastric emptying. So this can have an impact. It can worsen GERD. So it can worsen gastroesophageal reflux disease. And it can also make it difficult to give anesthesia. So we'll have to stop the medications a week or two before we have anesthesia and then put patients on clear liquids for at least 24 hours before. I think the good news is no off-target effects. The difficulties with the drugs is their power and then our need to respect that power. So because of that rapid weight loss, we also see an increase in gallbladder disease, gallstones, and cholecystitis. And that occurs in about 2 to 3% of patients who are taking these drugs. The risk benefit, it's always what we're thinking about with our medications. And when we're using these medications to treat obesity, that risk benefit profile is really in our favor. However, it's not there for cosmetic benefits, because for a cosmetic treatment, you need something that has essentially no risk at all. So it's powerful medications, some things that we're well aware of that happen, overall very safe, and we have a lot of knowledge over that 19 years of experience with the class.
Great, thank you, Donna. And my next question is, Patty, could you take a few minutes to tell us about your own experiences?
I'd be happy to. I've had obesity since childhood. It's not a choice. I've been ridiculed and bullied my entire life because of my body size. And my obesity grew more severe as I got older, which is pretty typical as I moved into adulthood. Most people who have childhood obesity carry it into adulthood, and it often gets worse, which is exactly what happened with me. I have been told my whole life it's all about willpower, and this is easy. You can lose weight, it's easy. You just need to stop eating, push away from the table, put down the fork. You're just not dedicated enough to it. So I always thought it was my own fault and that I carried extra weight. So I tried many diets, anything that seemed realistically possible. I didn't do the really outlandish things. I was thoughtful about the diets I chose, and they would usually work for a little while. And then they'd stop working and I'd regain the weight I had lost. And each time that happened, I was more and more ashamed because I thought that was all on me. Because that's what everybody told me. Society, friends, family, medical professionals. Everyone said you just needed more willpower. But you know what? I knew all along there was something more to it. Because I'm not lacking in willpower. I have a law degree. I've won awards as an attorney. I have great family and friend relationships. But in this one area of my life, despite all those successes, I couldn't manage my weight. And it wasn't until I was in my 50s when I started working with an obesity medicine provider that I started understanding more. He understood the biology behind obesity, just as our experts here today do and have mentioned. And he didn't judge me for my weight. He knew I had tried everything I could think of to manage my weight and just hadn't been successful. And he offered to help me. And we've gone through various iterations of treatment. Most recently, I have been on a GLP-1. I tried one a number of years ago and had very bad side effects from it. And it wasn't something I could stay on. So it took me a while to try a second one. And I did that and have had minimal side effects. I've had some, but they've all been very manageable and have not really interfered that much with my life. All told, I've lost about 30% of my body weight, of my initial body weight. And not all that was while I was on GLP-1s, but GLP-1s certainly have helped me. They've changed the way I think about food in the sense of I don't have the same food noise running through my head. I don't have the same drive to eat that I had before. It's changed what I want to eat. But I want to make clear that this isn't the only thing I've done to advance my health. It has taken some psychological support for me because of the weight bias I faced. It's taken a dietitian support. It's taken some movement support. It takes all of it. And my health, most importantly, has improved. I've dropped some of my medication, my blood pressure has improved, my mobility has improved. And that's what these medications are designed for. They're to treat obesity. It's not just weight loss, it's all about health.
Thank you so much, Patty, for sharing your perspective. We really appreciate it. Ania, my next question is for you. I know you recently appeared on Oprah to talk about obesity and weight management, and you took a moment during that to acknowledge that we need to shift the culture from blame and shame to compassion and care. How do you think increased access to GLP-1s might change the culture of treating obesity within the medical community? Could it advance that compassion and care that you were asking for, or do you think it could do the opposite?
So thank you for that question. And first, I want to thank Patty for continuing to share her story so vulnerably and so bravely as she does every time. And I still remember the first time that I heard Patty speaking and was just so impressed with everything that she does. And her story is one that just resonates with so many of our patients and literally is the reason why we do what we do. So in terms of shifting this culture from shame and blame and everything that Patty experienced, it's so critical. It's so critical to focus on compassionate care. And the way that I think about it is, okay, if half of Americans have obesity, half of Americans did not wake up one morning and decide to have obesity. So as Patty said, this is not a choice. This is not something that anyone chose. It's literally our body's biology responding to the environment that we live in. And so I think that these medications and focusing on understanding that biology and communicating that biology to patients as well as to all of us healthcare providers is really the key. Because if we treat biology or if we treat obesity and target the biology, we're treating it like we would treat any other disease. We're not saying that it's a choice. We're not saying it's anyone's fault because it's not. It's literally not. So these medicines, if they're targeting that biology, they're in essence helping to set our patients free from that shame and blame. And I do think that these medicines really do target the biology. And one of the inklings that we have of that is food noise. Okay, so a lot of patients will say that as they are losing weight, that the food noise, which this hyper focus on food, is lifted during that period of time when they're losing weight. And to me, food noise is the manifestation of biology. It's our body saying, no, 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 do not lose that weight. I want you to have that energy just in case. And the medicines target that. They're saying, no, you're full, you're good, you're satiated. That you're good. And so during that weight reduction phase, that food noise is often lifted from our patients as a burden because those medicines are targeting the disease process. Now, once patients reach a new weight plateau on whatever medicine they're taking, some of those cravings and the hunger can come back, but the weight does not. And again, that speaks to the medicine targeting that biology. So I think now we have these effective tools. They're targeting the biology, and hopefully they're helping to set us free and not to say eat less and move more, because that does not work. That is not treating the biology of obesity, but saying here is a highly effective tool that can help target your biology, and we're here to help you, and we're going to find a way forward, and we're going to help you live the healthiest life that you want to live, and we're here for you.
That's great. Thank you, Ania. My next question for you all is, what do you think is a priority for medical research to learn next about these drugs, or maybe some of their future applications? Donna, do you want to get us started?
Yeah, I will. So my thing is clinical research. And let me tell you, there's enormous excitement about the effect of this class of drugs on all of the chronic diseases, it seems, that are really our challenge in this 21st century. So we know that we have indications for the GLP-1 drugs for diabetes. Those were first. Then for chronic weight management or treatment of obesity, that was second. We also have indications for prevention of heart attack, stroke, and sudden death in individuals with diabetes, and most recently in individuals with obesity or overweight without diabetes. This is a very, very big deal. That discovery, the demonstration that we can prevent cardiovascular death, prevent heart attack, prevent stroke, and people who are at very high risk. It resulted not just in the FDA indication, but Medicare announced that it was going to reimburse for the use of these drugs in that patient population. That's a first for Medicare and obesity medications, and it's good. But we're also seeing emerge all of these evidence that really supports the effect of these medications in perhaps prevention of progression of chronic kidney disease. Wow. Treatment of heart failure, improving how patients feel and function who have heart failure, and reducing hospitalizations in people with heart failure. There's a lot of studies that are underway in neuroinflammation, in Parkinson's disease, in cognitive dysfunction, and Alzheimer's disease. So lots of very interesting studies are being done, hopefully, which will demonstrate an effect of these medications that's beyond weight loss, not just mediated through weight loss, but mediated through the actions of this GLP-1 molecule to really have an effect on what's called disease modification. So it's a really, really exciting time in clinical research. And it's going to be really interesting to see that play out. But there's another very important clinical research question, and that is, as we use these medications in an older population, in a population that has more advanced disease, we need to be careful about weight loss and its effect on bone and muscle. So at the same time, we're looking at the effect on these chronic diseases, we need to be solving this problem, because when we lose weight, we lose not just fat, we lose lean mass, and that includes bone and muscle. And we need to make sure that patients who are taking these drugs, we don't affect their body composition, and most importantly, their physical function. But I have to admit, I think the most interesting area of research is in basic science. Look, we do not fully understand how these GLP-1 medications work. We're taking this class of drugs forward using GLP-1 as the backbone, and we're adding these other nutrient-stimulated hormones, GIP, glucagon, amylin, long-acting amylins, to the mix, and it's a very exciting area of drug discovery. But I don't think we have the complete answer on how these medications actually work, and our basic scientists are going to have to help us on that.
Thanks, Donna.
Yeah.
Patty, Jamy, Ania, any other research priorities you want to discuss or highlight for our audience?
I will say one other thing. I think one of the biggest barrier to patients like Patty, and I think Patty described this a bit, is the nausea and vomiting. So as we take these medications further, we need to make them more tolerable, because we can't get patients to take the medications unless we can get over the tolerability issues. So currently about, I'd say 6 to 8% of patients who take the GLP-1 medications are unable to tolerate them, primarily because of GI side effects. And we need to solve that problem.
And I'll just add, in terms of the tolerability, we also know that one of the keys is going up on the dose slowly.
Yeah.
So we know that most of the side effects occur during dose titration. So that means as we increase the dose. So one of the things that we can do with our patients is go up more slowly. And the way that I discuss it is usually I say, well, the weight didn't come on overnight, so we shouldn't be rushing to have it come off overnight. So let's do it how it works for you. So if one of my patients is having nausea, we don't go up on the dose. We wait until their body gets used to the medicine. And then once the nausea abates, then we start to go up on the dose again. So I very rarely, for these weekly medicines, weekly injectable medicines, I don't go up once a month with my patients. We wait until their body is ready. And then usually in terms of those side effects, whether it's nausea or something else, they're significantly less. We see that significantly less. And if somebody is having side effects, regardless of how slowly we go up on the dose, and again, it's really important to start with the lowest dose and then go up from there, we'll switch medicines and see if another medicine is working better for that patient. So there are many, many options for that. I'll also say, I cannot agree with Donna more about the need to really understand the mechanisms of how these medicines work, and understand the effects that they're having in terms of weight or fat loss and their action in the brain, as well as their action in the periphery and some of these effects that she's talking about that may be effects on these other obesity-related diseases that may be separate from weight reduction. So I couldn't agree more. I think that's exactly where we need to do the research.
Well, I hope everybody was listening to Ania, the master clinician. Look, you can lose weight for way more than a year on these medications. What's the rush? Slow it down, please.
Well,
And now-
and something that this discussion highlights from a patient perspective is the need to have trained physicians and other medical professionals, which we're lacking right now. We need to have more people trained that know all of this and that can provide personalized care, obesity care to patients, because we're all different. We are not all the same. And in fact, I know some people that have taken GLP-1s and they just don't respond to them. They're just a different biology than I am because I've had a really good response to them. But we all need medical professionals that know about all of this.
Yeah. I hope Jamy, who's the president of the Obesity Society, has the plan for developing the skilled workforce that we need.
Well, Donna, we're working on it. And a lot of what we're working on is really trying to increase education and training, create more obesity medicine specialists. We've got more people interested in this field than we've ever had before. And I think this is a byproduct of the, advancement of the treatment offerings that we have. And it leads to the comment I was going to make on where do we need more research. Patty really kind of set it up quite nicely by saying, look, these treatments, as our toolbox expands, it means that we can actually do more personalized treatment, right? We can actually start to understand which treatment might be the best treatment for a given patient. And what does that look like long-term? How do we think about the combinations of bariatric and metabolic surgery with our first and second generation medications, with these newer medications that are being developed? As Donna mentioned, as we are looking at combining these GLP-1 based treatments with other nutrient stimulated hormones, these combinations will create really unique opportunities for us to target very specific diseases that are part of the obesity complex, right? And so it may be that we can say, well, you have heart disease and obesity, or you have liver disease and obesity, and we can target the treatments for those individuals in very different ways based on the combinations of different molecules that we have. So there's a lot of, opportunity here for us to really kind of understand, as Ania mentioned, right, it's in a response to the obesogenic environment, but everybody responds differently to that environment based on genetics, based on social determinants of health, based on any number of other factors. And so this is how we think about any other area of medicine. It's not just one cancer that we treat. We treat very different types of cancers, right? We even have different subtypes of type 2 diabetes, right, that may require different types of treatments. And we understand this with obesity. And now we're finally getting to a point where we can think about using that information, that knowledge, to personalize treatment.
Yeah. So I'll just expand a little bit on what Jamie's saying, and with the idea that, just as he said, there's not one type of cancer, there's not one type of obesity, there's many different types of obesities. And we don't talk about that enough because we're not far enough along yet to know how to identify those different types of obesities. So as Jamie's saying, and everyone else is saying, well, maybe we need different types of treatments for those different types of obesities. So if somebody doesn't respond, right, if somebody doesn't respond to one of these newer medications, maybe they'll respond to one of the older ones, or maybe they'll respond to bariatric surgery, or maybe they'll respond to something that we have yet to discover or develop. I mean, the main thing is to not lose hope and basically continue doing the research. And then just to come back in terms of these nutrient stimulated hormones, right? So GLP-1, GIP, amylin, all of these different hormones, these pathways are very intricate. And they all work together. And that really highlights the complexity of obesity, or the complexity of the different types of obesities that we need to begin to understand. So we're really early on in our understanding, and we're lucky to have these tools, but we need to understand how they work and who they work for.
Thank you all. Some very fascinating areas for science to dive into in the next couple of years. So Donna, I want to come back to you for a minute. There have been some headlines in the past few weeks about people being hospitalized and even dying after taking compounded or non-FDA approved copies of these drugs. In your experience, what factors are at play for patients who turn to a compounded version of a weight loss or diabetes drug?
Yeah, thanks for that. I don't think anybody anticipated this incredible rise of compounding around the GLP-1 drugs, but it is really a phenomenon. And I think what caused the emergence of this compounding molecules is the fact that the drugs are expensive and they're not reimbursed for most people who need to take them by their health insurance. The drugs were initially in very short supply. That's been solved for tirzepatide. It's no longer on a shortage list. And the others are building factories to address that shortage problem. But also there's this incredible patient demand. I think the patient demand speaks more to cosmetic purposes. So I think our culture has a real drive for slimness. And so many people are seeking the compounded products because they can't afford the real thing. They can't access the real thing, or because they don't meet the qualifications. So we have a lot of compounded drugs that are used off-label in people who don't really need to lose weight for health reasons. But what compounded drugs are is they are not the FDA approved product. They are not approved by the FDA, and they haven't gone through that rigorous process for pre-approval and marketing of a medication. But the law does allow, if there's a shortage, for a molecule that's what the FDA calls identical or nearly identical to be prepared and sold to individuals by these compounding pharmacies. Now, the molecules are not coming from the companies that make the branded products, not the companies that are making branded tirzepatide as Mounjaro, or as Zepbound, or semaglutide as Wegovy or Ozempic. No. These molecules are mostly coming from China, other parts of the world, and then the molecules are shipped to the United States. They're either sold online or in these compounding pharmacies. The problem with this is that we have no way of knowing what is in the vial that is labeled semaglutide, tirzepatide, whatever. We have no way of knowing what is in that vial. And if it is only the bright molecule, or if it has other things that are in there, if it's pure, or if it has adulterants, or maybe even bacteria or whatever. So yeah, there have been reports of serious complications and deaths with compounded drugs. I empathize with people who need these medications for health reasons, but there's just no way that I can endorse the use of compounded medications, because I cannot assure that the compounded medication that you are being sold has the drug in it in a safe form. Until I can assure that, I can't support it. I think that, let's remember, over time, these drug prices are going to come down. and we're going to solve the shortage problem. And to me, the most important thing is what I was taught in medical school. First of all, do no harm. So I worry about the safety implications of compounding. Thank you.
Thank you, Donna.
Yeah.
So my next question for you all is, there's been a national conversation started over the past year about how these drugs might reshape American health on a pretty broad scale. And it sounds like from our conversation today, we're seeing mixed results among patients. And we started this conversation with the fact that these are not necessarily a magic bullet for everybody. But how do you see these drugs changing what we need from the healthcare system in the US? I know there's been speculation about who's going to pay for them, thinking about how we should address mitigating equity and access issues now. But what changes to the healthcare system are you all anticipating, and how do you think the system is likely to adapt or react? Jamy, let's start with you.
Well, I think there are going to be a number of changes that will have to happen, Megan. And I would start with the fact that we need to support our frontline medical providers to be engaged in the treatment process. And that goes to what Donna was mentioning earlier. We need more education in the training process. We need more support around our clinicians who are providing treatments. If by way of comparison, we think about metabolic and bariatric surgery, where we wrap around care that includes up to 6 months of preparation for surgery, and then several years of support and follow-up after surgery with dietitians and nutritionists and exercise physiology and behavioral health. And we're seeing now weight losses that are approaching the same weight loss on average as metabolic and bariatric surgery with these medications, but we have very little of that support to help mitigate any of the potential adverse events or the long-term, sort of negative consequences that Donna mentioned, right? The loss of lean mass, including skeletal muscle and bone. We would all love to be able to be seen by Dr. Jastreboff, right? I mean, it would be great, but she can only see so many patients. And we need to have the level of expertise and support across the board in terms of helping healthcare providers be able to get patients started on treatment, and those that need more help, need the expert level of help, then have a specialist class that are able to step in and help in a referral way to help patients who might need additional support and resources. So I think that's a really important aspect of what we're talking about. If we're talking about 40 to 50% of people who could benefit from these treatments, we don't have enough providers who are adequately engaged to be able to support that. So that's really important. I think the next piece of this is really about health equity and ensuring that when we think about the treatment of obesity, we have with these tools in our entire toolbox the wherewithal to be able to eliminate health disparities, to be able to adequately treat people who need that treatment, and make sure that they get the care that they need in a way that's non-stigmatizing, that's compassionate. But the only way we can do that is if we actively address those issues that help to create the disparities in the first place. And that means we have to think about what our healthcare system looks like, right? Who has access to care in the first place? And why is it that treatment of obesity is not something that's, supposed to be required and included and covered in everyone's health benefits? Why is it that for Medicare, these types of medications and treatments are excluded as a part of coverage, right? That has to change if we want to see the benefits spread equally across our population. So these are really important aspects of the healthcare system that I think absolutely have to change. And our patients are going to demand that of us, right? They're not going to sit by and see that here's a treatment that could save my life, that could take away 3 other medications that I'm dealing with. And we've agreed to treat those things, but we won't treat the primary cause, as Ania said, right? We won't treat obesity first. We will wait until people develop all of these complications of obesity, and then we'll throw everything at that. But again, we're still not treating the primary disease. And so that fundamentally has to change. And that changes as a result of the change in bias and stigma, because that's what this all comes back to, is we have evolved our thinking about obesity from a biased framework. And so if we think that obesity is the individual's fault, then it's on the individual to fix it. And we've learned today that it's not. And so as we learn that, it requires that we do something different.
Thank you, Jamy. That's a perfect lead into my next question, which is for Patty. How do you think GLP-1s might affect the ongoing and evolving conversation about weight bias, both in medical treatment, but also in society at large? What are your thoughts?
Yeah, I think Jamie's spot on about how weight bias is playing into the systematic problems here. I'm hoping that these medications will open the eyes of medical providers to understand that there are, and that they'll take an interest and want to learn for their patients about these medications and learn that there is biology involved here. It's not just a matter of eating less and moving more. Some of these medications can help people do exactly that, eat less and move more. But we need the help to begin with to get to that goal. And I'm hoping that as the science evolves, the medical profession will evolve with it. I think we need more efforts at training people, especially in, say, medical schools. Let's get them on the right page to start with, because a lot of their patients are going to have obesity, no matter what field they're in. So that's part of it. Societally, though, it's very difficult. Weight bias is ubiquitous in our society. You see it everywhere. And, we've even had members of Congress say, I'll pay for a gym membership for the person, but I'm not going to pay for any medications for somebody that's fat. Well, that's a manifestation of our society's view that that we can all do this on our own. And I think the medications I think the jury's still out, but some people have said this is just another easy way out. If you just buckled down, you wouldn't need this medication. On the other hand, other parts of society have said, this really makes a difference in how I'm viewing obesity and how I'm viewing weight, that there actually is a biological component. So I think the jury is still out on how that's going to play out. But the health equity issues are not moving in the right direction. Several states do cover, have full medication coverage for obesity in their Medicaid programs, but several are starting to cut back. Same with state employee programs and other employer programs where they're removing coverage that they once had. And I'm not that familiar with other areas of medicine where we're looking so closely at a cost-benefit analysis. I mean, what do we get out of healthcare? We want a better quality of life, or maybe healthcare saves our lives, right? We don't say, and how much is that going to cost? But we do in the obesity landscape. And some of us are lucky and we have coverage, but healthcare shouldn't come down to luck. It's my bottom line. There needs to be access to these drugs through payers that pay for medications, be they public payers or private payers.
Thank you so much, Patty. And thank you to all of you for taking my questions. We're now going to open it up to questions from the audience. We've got about 15 minutes for that. So just as a reminder to our audience to ask a question, you can just type it into the box below your video player that's labeled Slido. And you can also upvote questions that have already been asked that you would like to hear. So I'm going to start off with a couple questions that kind of go back to the basics on GLP-1s that our audience has upvoted quite a few times. And I think we've touched on some of these, but I'm hoping you all can dive in a little bit deeper. So our first question is, how safe are new drugs for weight loss? I think we've talked about some of the side effects, but are there any studies that indicate these can cause damage to other body systems? Are there any other things you want the audience to know about this?
I'll take that one. So I think, the good news is we have 19 years of experience with the class. And that gives us a lot of confidence that we know what we're doing here. I think the first thing to recognize is that these are peptides, they're proteins. So it is possible to have allergic reactions to them, and they can be serious. We would never give these medications to individuals who have multiple endocrine neoplasia type 2 or who have a personal or family history of medullary thyroid cancer. And the reason for that is in rodents, the GLP-1 class of drugs, it's a class effect, will increase thyroid C-cell tumors, which is equivalent to the human medullary cancer. So I think this is an abundance of caution. We have never in our post-marketing surveillance shown a link between the drugs and this type of thyroid cancer or any type of thyroid cancer or any type of cancer. But because of this finding in rodents, that is the one area that we will not prescribe, the one condition where we will not prescribe the GLP-1 drugs. Pancreatitis, we're sensitive about that. We know that individuals with diabetes have increased rates of pancreatitis. We've never linked the GLP-1 drugs to pancreatitis definitively, but we're still very cautious and careful about that. And when patients develop symptoms of pancreatitis, we'll stop the drug and we will not restart them if we prove they have pancreatitis. So those are our two biggest precautionary areas. But I think overall, the safety profile of these drugs is known. It's there. We know what to expect. Additional comments from Jamy or Ania?
I mean, I'll just add that nothing in life is all good.
Yeah,
Right.
that's right.
Like, I'll just add that. So the thing is that we can say 20 years of data with GLP-1 receptor agonists and safety signals have not emerged. Do I have 100 years of data? No. So what does that mean? Well, that means that we need to continue to monitor as these medications are used and monitor real world data and see how everyone does. Whenever you give medications to millions of people, you want to know what's going to happen. And so just as we can say, well, there's many medications that have been around for many years, what other medicine has hundreds of years of data? Now the lifespan, let's hope that it is, 100 years or something within our lifetimes. So yes, by then we'll have that type of data. But I think the data is good in terms of everything that we have now.
Yeah.
Thank you both. So our next question from the audience is about continuous use and sort of the use course of this drug throughout someone's life. So to maintain weight loss, do they have to use the drug continually? Once their goal weight has been achieved, what are the protocols for tapering off these medications, if at all? And what happens in your experience when people stop taking this medication?
I mean, I guess I can start and others can add because we're learning a lot here. But if you think about any chronic disease, it requires chronic treatment, right? So if you think about somebody with high blood pressure, they take a blood pressure medicine, their blood pressure improves, and that's awesome. Everybody's happy, the patient, the provider, great. Now, what happens if that blood pressure medicine is stopped? Well, the patient's blood pressure goes up, and none of us are surprised, right? The medicine doesn't work if it's not taken. With obesity, the goal is not weight loss. Or I guess I should say they're not weight loss drugs. They're anti-obesity medications. So they're medications that target the physiology or the pathophysiology, I should say, of obesity. So what does that mean? That means the goal of using these medications is decreasing or re-regulating how much energy or how much fat your body wants to carry. Okay, so we talked about that at the beginning of the session. So when you take one of these medications, it re-regulates or decreases the amount of energy or fat or weight that your body wants to carry. Now, what happens when you stop taking that medicine? Well, that amount of energy or fat that your body wants to carry goes back up. So far what we're seeing is that in most of our patients, when they stop taking the medicine or we decrease the dose or something, they start gaining back the weight. And that makes perfect sense. Obesity is a chronic disease. It requires chronic treatment. We want to make sure that that re-regulation of what we call defended fat mass, or how much energy or fat your body wants to carry, is maintained at this new place, this new place where you carry a different amount of weight. Having said that, there's differences in how much weight people lose, there's also differences in terms of how much weight people gain back. So most of the time when my patients say, okay, I lost the weight, can I stop taking the medicine? What I say is, well, how about we try decreasing the dose and see how you do? Now, if we decrease the dose and they're able to maintain the weight and they feel fine and they're not struggling to maintain that weight reduction, then we maintain that lower dose, or we can try and decrease more. But what happens most of the time is that they come back and they're like, oh, I've gained back, 15 pounds. Can we go back up on the dose? So more work to be done. But I think for now, the answer is that in order to treat a chronic disease, we have to continue chronic treatment, maybe a different treatment, maybe a different medicine or a different form of treatment. But for now, that's what we're seeing.
Thank you. Our next question is, can you please discuss the weight loss drugs offered directly to consumers on TV, online, or through certain weight loss programs at significantly lower cost? Are they legitimate imitations of branded products that have been well studied and approved, and what are the risks?
So I can start with this, but Donna touched on that when we were talking about the compounding issue. So there's a broad range of what might be offered online through commercially available weight management treatment options. And some of those services may be offering, actual branded medications that would be prescribed in the same way that you might get prescribed in in your local clinician's office. But some of these options, like a Medi-Spa or something, where somebody is, advertising buy one, get one free, those types of things, those are often not in the same category. So if it's not brand name Mounjaro or Zepbound or Wegovy or Ozempic, it's unlikely that you are getting the actual drug. And I think people, all of us that are here are, have been publicly opposed to the idea that people use these unbranded, untested, compounded alternatives, because, as Donna said, we don't have line of sight into where they come from and how they're produced. And we don't often understand, when someone shows up in my clinic and they say, I'm having certain side effects, and those side effects aren't consistent with what we've generally seen in the clinical trials and the experience that we have with the medications. It's hard to know, is that because of something else that's added to the medication? So these offerings, I would say you want to really look for, one, is the provider and the type of service being provided, is that comprehensive, and is it something that is really based in science, versus where they're just trying to sell you something in order to get your money. And so it's unfortunate that we've seen a proliferation of these, and there are good programs and good services out there, but you really want to go for, in my opinion, things that we know we have safety and evidence around efficacy.
Great, thank you, Jamy. Well, it looks like we have about 2 minutes left, but I'll try to throw one last question your way if we can squeeze it in. It says, coming from the public health perspective, Ania is naming the cause of the symptom, obesity, as the obesogenic environment, and that GLP-1s are the treatment. I'm curious the panel's thoughts on how we can address the cause versus focusing on the treatment of the symptom.
Yeah. Well, I'll say I want the last word. So I think that, the obesogenic environment is so powerful. Our public health approaches to this have been things like front of label front of package labeling, trying to improve the built environment, more parks, more walking paths, trying to build into educational programs into our schools. I think what we really need is to respect the power of the obesogenic environment and to recognize, to change that, it would really take a lot of reformulation of our food environment, and it would take a lot of changes to our built environment, into how we work and how we play. I just think we need to have respect for that, for what it would actually take. But I am all for it.
I
Totally
think we're
agree.
all for it.
Totally agree. It's a systems issue. It's not a one solution issue. There are multiple things that we have to do.
And this would, address all these, or so many other diseases, right?
Right.
So we don't ask of this for diabetes. We don't say, well, why are we using medications to treat diabetes rather than, than fixing the environment. So I think we have to ask ourselves why we ask this about obesity. And I think absolutely we need to fix our obesogenic environment. We need to work on that, just as Donna said, and really come to that together. But then we also need to ask ourselves, why do we not ask of this for diabetes, for hypertension, for cancer, for all these other diseases? And we should.
Great. Well, thank you all so much. Unfortunately, that is all the time we have for today. We had so many great questions. On behalf of the National Academies and the Health and Medicine Division in particular, I want to thank our panelists so much for their time today and for being a part of our very first Healthy Exchange. We are very grateful for your time and expertise. And for our audience, the same to you. Thank you for taking the time to join us. As we said at the start of this event, we will be hosting these once a quarter. So we invite you to join us at the next webinar in early 2025. And we hope to hear your thoughts about today's event as well. So thank you all and have a great day, everybody.